evening, everyone. My name is Bethany Yeiser. I'm president of the CURESZ Foundation. CURESZ stands for Comprehensive Understanding via Research and Education into Schizophrenia. And I'd like to welcome you to the first of our virtual lecture series in fall of 2025. I'd like to introduce our distinguished guest, Leslie Carpenter. She is a legislative advocacy manager for the Treatment Advocacy Center, a co-founder of Iowa Mental Health Advocacy, and a lobbyist in the Iowa legislature. She's a retired physical therapist, actually, who now works to improve the mental illness treatment system. Welcome, Leslie Carpenter.
Thank you, Bethany. Thank you for having me. So thank you to all of you who are attending tonight to hear about how we have come from asylums to the situation we find ourselves now of apathy, and how we are failing people with severe mental illness. Just a little bit of background so that you have an understanding about why I'm speaking to this topic. I am a retired physical therapist. I retired early from that career about 6 years ago, when I recognized that if I wanted to affect some of the changes that I believed were needed in the treatment of people with severe mental illness, that I needed a lot more time than I had while I was working and taking care of patients and managing a staff. And so I have spent a lot of time at the local level, state level, and now national level, working on various projects and solution-oriented committees for improving the mental health care system. And I always like to make it really clear that I myself am not a mental health person or a mental health therapist or professional. And my path to SMI advocacy came because my husband and I have 2 adult children, and I'm happy to tell you that our daughter is healthy and well, but our son is not. He lives with a very severe schizoaffective disorder, and he's been in and out of the revolving door of all of these places, from hospitals to trying to live in our home to trying to live in the community with our support and the support of community mental health services, as well as, you can see, even the state hospital. So we've experienced the mental health care system through trying to help him stay in treatment in pretty much every setting that's possible in the state of Iowa, and have extensive experience in it. And Bethany asked me to give you a talk about the history of where we are in the way that we are treating people with severe mental illness. And we could go back centuries, but I decided to start back just in the 1800s. And if any of you are sincerely interested in learning more about this, I can recommend a couple of good books. One is No One Cares About Crazy People by my friend Ron Powers. That's a very good book, but if you're an empath like me, I will tell you that one was a difficult read for me, because he brilliantly intertwined the story of his own family with 2 sons who have severe mental illness with the history over the course of time of how we've treated people for centuries. And it was a difficult read. The other book that I could recommend is called Insane Consequences: How the Mental Health Industry Fails the Mentally Ill by DJ Jaffe. This one is a little bit of a drier, policy-based read, a little bit easier to get through if you care about somebody with a severe mental illness, and well-sourced. So I decided to start back in the 1800s with a fairly well-known advocate that most of us on this call probably already know about. Her name was Dorothea Dix. And she is somebody who decided to look into the care of people who had mental illness and who were also poor in Massachusetts, because she found the circumstances that they were in to be pretty dire and atrocious. And she published a very fiery report called a memorial, and it was published to the state legislature in Massachusetts at that time. And I did provide Bethany with a list of all of the links to some of the reports that I'm going to be mentioning today. And if you're interested, that link is in the materials that I'm pretty sure Bethany will be sending out. And her report and then her continued lobbying on it resulted in a bill in the Massachusetts legislature to expand the state's mental hospital in Worcester at that time. But that was just the beginning because she actually went ahead and helped to create the asylum movement, if you will, across the entire United States. And if you drive around in various states, you could see signs put up to give her attention and credit for having created actual healing asylums. It really did help improve the care of people at that time. A few years ago, I was asked to give a talk at the state hospital here in Independence in Iowa. And while we were there, they invited us to take a tour of the museum wing of the hospital. And I saw this picture, this handout that they had up on the wall, which was basically a list of guidelines for the people who are working with people that have mental illnesses. And I apologize for the picture quality, but I wanted you to see that that's actually a document from 1878. And I typed up what it was telling people to do over on the left side here. And you can see that they were actually pretty reasonable guidelines. Kind words cost nothing. Occupation is the beginning of cure. Strive to be quiet and mind your own business. The law of kindness will be subject to no exception here. And oh, how I wish that this had been the way that they had continued on. But sadly, we all know that things did change. But in the beginning, they were well intended. They were placed in safe havens away from busy cities in recognitions that urban environments are more difficult. And some had gardens, farms, places people could work and find purpose. And those of us in this space know that it really does help if somebody can find purpose again. It leads to a more full recovery. And some were actually quite wonderful for quite some time, but then things changed. And a lot of problems arose kind of all around the same time. Civil commitment laws became too lax, and it would be too easy to end up having somebody committed to an inpatient institution for the rest of their lives. At the time, a husband could get angry with his wife, who might not even have a psychiatric illness, and he could get her admitted, which I think we can all agree is not appropriate if somebody doesn't have a mental illness. And effective treatments were very limited back then. And so experimentation was happening with very little oversight, and the facilities were becoming overcrowded, underfunded, and understaffed. And so there were a lot of neglect and atrocities happening to people who had no ability to get out of there, which was really tragic. And so some good investigative reporting happened in this article that's pretty famous called Bedlam. It was published in Life magazine back in 1946. And it created public outcry that began the deinstitutionalization movement. And that started really with the Community Mental Health Act in 1963. And at the time, Thorazine had come onto the market, and initially they thought it was going to be a cure for schizophrenia. But as we all know, it didn't turn out to be. And it really did propose deinstitutionalization with a shift to bringing people closer to their families in community mental health centers. And it was well intended. And it actually ended up, though, being the very last bill that President Kennedy signed into law, actually on Halloween of 1963. And just a couple of weeks after that, as we know, he was killed, and we never had the champion to build out all of the intended community mental health centers. And then a couple of years later, the federal budget had been shrinking due to the Vietnam War and other factors. And there was another well-intended law that was passed. And it was a law that went into place that was sold as being helpful. They sold it as saying, hey, if we can keep facilities smaller, we will avoid atrocities. But really what it was part of the Medicaid Act of 1965. And that act in and of itself was quite wonderful, right? It's our social safety net. But in order to get that bill passed into law, They pulled out what's called the Institution for Mental Diseases, or IMD exclusion. And what it does is it prohibits federal matching Medicaid dollars for any facility with more than 16 beds dedicated to people who have a quote mental disease. And what they were really doing was doing a cost shift from the federal government to the state government. That was what they were doing in order to get the bill across the finish line. It was basically what we call the hot potato. Nobody wanted to have the responsibility of taking care of the people with the most severe mental illnesses. And it's very uniquely discriminatory. And again, if you're interested in more information about this, I highly recommend reading a couple of pieces that Michael Gray has written. This is a quote from one of the pieces. He said, a discriminatory piece of Medicaid law, the Institution for Mental Diseases Exclusion, is denying people with mental illness equal levels of treatment as those with primary health care needs. And he's exactly right. It is important to point out that there are a lot of efforts to get insurance parity for mental illnesses to be like for any other health condition. But those of us in this area that know, we know that most people with severe mental illnesses have Medicaid for their insurance. And as long as this IMD exclusion is in place, there is no parity for our loved ones. And it's important to educate people about what it's really affecting. I have spoken with legislators who really thought it was all about state hospital beds, and it's partially affecting that. But it really affects any facility with more than 16 beds dedicated to people with a mental disease or a mental illness. So it does affect hospital care, it does affect state hospital care, but it also affects diversion, access, and crisis centers, the things that are being built out at the beginning of the continuum of care. And it also affects residential treatment facilities that are providing longer term residential care. So it's important to understand it's affecting people's access for treatment from the beginning to hospital, to state hospital, to long term residential. So it has a severe impact on the people with the most severe illnesses. And so the question is, did it avoid atrocities? And the simple answer is no. Since the IMD exclusion took effect, a shift has happened from hospitals towards homeless camps, jails, prisons, and I should have on here graveyards, right? We do know people are dying as a result. So back in 1955, we were at the peak of our state hospital beds at that time at about 558,000 all across the country. And I think we can all agree that that was way too many. But now, across the whole country, we only have about 36,000 of those beds. And that's about 134,000 than we really need, per the ratios recommended both by the American Psychiatric Association and the Treatment Advocacy Center. Our homeless population is growing. It's now up over 771,000. And while people with mental illnesses are not comprising all of that population, it's estimated that they're about a third of that population. And our prison population has within it about 380,000 people with a severe mental illness. And it's important for us as advocates when we're educating others about this to point out that these people are not endemically criminals. If they hadn't had the mental illness, they would not be ending up in our prisons. How do they get there? Well, maybe they're untreated, they're homeless, the voices take over, and they commit an act, and off the prison they go. Another common pathway is maybe they're homeless and they sleep in the wrong place. They get arrested for trespassing. They go to jail, where, because they're untreated and in psychosis very often, they are not able to follow the instructions of the jail staff, and they accrue further charges, and then off to prison they go. But there's another pathway that's happening all the time, unfortunately, where maybe a family is recognizing the crisis for their loved one. They manage to get them to the hospital in the midst of that psychiatric crisis. And there, maybe before they're treated and stabilized, they act out and they assault a staff member. And what are the hospitals doing? Well, Rather than instituting better safety measures to keep the staff safe and the person safe and get the person the treatment they need for the brain illness that they came in the door with, no, they are picking up the phone and they're calling the police and having the person arrested for the sin of having a brain illness that they have not yet responsibly treated. And that, in my mind, is the much larger crime. And this graph does a really good job of showing over the years, as we've shut down our public mental health hospitals, we've been filling up our jails and prisons. And so currently in the United States, we have about 10 times the number of people with SMI in our prisons and jails rather than in our state mental hospitals. And that's a horrible situation. And for too long, we've been accepting this very false premise that everyone is better off in the community. It is up to us to responsibly call out the fact that as long as there are 140,000 people with SMI estimated to be homeless and on our streets, they're not better off in the community. As long as we have 2 million people with SMI cycling through our county jails every year, they are not better off in the community either. And we don't even know how many are dying, but I think we can all recognize it's too many. We have to push back and point out that not everybody is actually doing better in the community, and we need to be honestly dealing with that. And we propose that the pendulum needs to swing a little bit. It is enough. Enough time has passed to think that everybody belongs in an institution. Nobody thinks that, right? But we also have to recognize that not everybody is doing okay in the community. And we need to recognize there might need to be a slight shift back to meet the needs of the people who are most seriously ill, because otherwise they're going to continue to be criminalized and homeless and incarcerated. And long-term options are really necessary. We need to be able to enable hospital stays that are long enough for actual stabilization, not just getting somebody medicated enough so that they are less acutely symptomatic. And we have to recognize that there are some people who truly do need permanent supportive housing with 24/7 staffing, with medically necessary treatment available to them in that setting. And with the IMD exclusion, there were some short-term workarounds. Prior to 2005, states could get waivers if they could show innovations, but those waivers went completely away in 2005. And so we saw even more reduction in terms of hospital beds at that time. In 2018, the IMD waiver did return, but it only covers 15 days of hospitalizations for most of them. Some IMD waivers, they work it out with the use of other waivers as well and get about 60 days of hospitalization, but most of them are only covering about 15 days, which, as we know, is too short. So there have been some bills in the past, a lot of them over the years, to try to repeal the IMD exclusion. An example of one was HR 1201, which would be a full repeal. And another one was the Michelle Alyssa Go Act, which would change the bed limit from 16 to 36. That bill has not been reintroduced in this session of Congress yet, but we are expecting that it may be very soon reintroduced. The good news is we do have another bill that has been introduced already called HR 4022, called the Increasing Behavioral Health Treatment Act, that has been filed in this session, and they are up now actually to 6 co-sponsors. And it's been referred to the House Committee on Energy and Commerce. So if this is something that's important to you and you want to be advocating about it, I would highly recommend writing your U.S. representative and urging them to think about signing on to this bipartisan bill. And you may be wondering, why hasn't this passed? Well, in the past, when this has been introduced, the idea of repealing the IMD exclusion, the Congressional Budget Office came out with a huge fiscal cost in terms of how much it would cost Medicaid to do this. And then also there were advocacy groups like the ACLU, like disability rights organizations that have a fear of returning to the institutions of the past. And we have answers to both of these, but it's important to know that these are significant factors that our members of Congress really do listen to. So some key data to share is that when the Congressional Budget Office came out with their report looking at the fiscal impact, they only looked at one side of the equation, how much it would cost to provide the Medicaid dollars for facilities with more than 16 beds. But the other side of the equation is kind of answered with this report that was published in 2021 from the Schizophrenia and Psychosis Action Alliance called The Cost of Not Treating Schizophrenia. And they found that for 1 year in 2020, the cost of not treating people with schizophrenia was actually at about $282 billion. And we were getting worse outcomes. And so we always like to point out that actually it would cost us less to do the right thing in the first place, and we can get some better outcomes. The Michelle Alyssa Go Act, which again is likely to be introduced very soon by Representative Dan Goldman from New York, would propose a modification of the IMD exclusion to change that bed limit from 16 to 36. The reason this is thought to be somewhat of an easier lift to get past is because it would provide less cost, right, in terms of not having a full repeal. But also it allows for an economy of scale because it's pretty expensive to run a 24/7 facility for only 16 patients. Moving it up to 36 makes it a little bit more financially solvent for these companies to do this. And I would say that what we recommend is advocate for all of these bills. Advocate for the full repeal, also advocate for the Michelle Alyssa Go Act. And it's basically from this principle of we can't let perfect get in the way of better. We need to provide more access. And if all we can get is this bill to pass, it's still a step forward in terms of taking care of people with SMI. The other good thing about HR 4022, the bill that has been filed for a full repeal, is that it does call for additional things like enhancing outpatient community-based mental health treatment, establishing more crisis response systems, improve data sharing between healthcare providers, which helps to break down the silos that often exist in the system now, implementing a screening process for co-occurring physical and mental health conditions, and then also requiring annually reported detailed data about the mental health treatment, which is very helpful because without data, it's really difficult to analyze the system and understand where we need to be investing for improved services. And to the point that was raised earlier about, well, what about this fear of having everybody go back to an institution? First of all, nobody's advocating for everybody to go back to an institution for the rest of their lives, for one thing. The other thing is that being in psychosis is not a right that we need to protect. It's an illness that we need to step up and compassionately and effectively treat. And this is just from a quote that I took from DJ Jaffe, the author of that book that I was referring to. And when we talk about this civil rights discussion, we do have to find the appropriate balance. We do not want to impose too much on people's civil rights, absolutely. But we need to make sure that we're not leaving them to die on our streets with no treatment. We have to figure out the right balance. And it's important to understand that state hospitals offer services that no other place offer. They are publicly operated and funded, and it's important to know that most of the hospitals in our country, about 82% of them, are private. And private facilities will not admit patients that have treatment mandated by the criminal, legal, or forensic system. And state hospitals are just about the only place that can offer long-term care that no other facilities are providing. That's why we still do need state hospitals. And the recommendation is that for about every 100,000 people, we should have 30 to 60 inpatient beds, combining both private and state hospital beds for a functional system. But no state in our country is achieving that ratio. We are severely underbedded. And the result of that is that we end up leaving people in what we call the revolving door churn. People are going through repeated ineffective hospitalizations, homelessness, and oftentimes incarceration. And it's a real problem because it also results in the average duration of untreated psychosis in our country to be 74 weeks. That's an incredibly long time. It's about a year and a third. Can we imagine any other illness that's left untreated for that length of time? And the problem is, while untreated, the person's brain experiences further damage. It makes it harder to pull the person back out of psychosis. It reduces their insight into their illness and worsens anosognosia. And their life circumstances are much more severely at risk, right? They're at more risk for intersections with the criminal legal system and homelessness and death. And in some states in our country, a person can only get into the state hospital through the criminal legal system because all of their beds have become forensic beds and none of their beds have remained to be civil beds. And I know we talk with families sometimes who have a loved one who ends up getting arrested because they're sick. And they think, oh goodness, the judge has decided to send them for competency restoration. Isn't that wonderful? My loved one is finally going to get treatment. And the thing that we like to help educate people to understand is that competency restoration is not treatment. It is a legal part of the legal process where the person is provided medication and classes to learn about court, just enough to get the person well enough to be able to recognize a judge and a courtroom and their lawyers so they can be competent to stand trial by participating in their defense. And it's really important to understand that that's not full treatment, right? It's not what we would really hope for. But generally, it is provided for at a state hospital or another carceral facility, and sometimes in the community, but rarely. And there's a consequence of having too few of those forensic beds as well, because in our state, in our country, we have about 5,576 people waiting for admission to a state hospital to get their competency restored. That is a lot of people. And so the median wait time is about 60 days. And unfortunately, in many of our jails, they're not getting treated during that wait time, especially if they have anosognosia and they can't consent to treatment. That's a long time for somebody to be sitting in a very carceral setting without treatment for their psychosis. And so a lot of states are facing class action lawsuits because of the wait times for these competency services. And so what we propose at the Treatment Advocacy Center is that in places where there are established AOT or assisted outpatient treatment programs, we recommend that the prosecutors and the judges consider doing what we call dismiss upon civil commitment with AOT. And we have a wonderful video and handbook that's found right on our website. And the idea is for them, if it's a low-level charge and the person's not at high risk for violence, that rather than just have them go for competency restoration, wait for it, eventually get restored just to competency, then go back to the jail, then go to the court for their trial, where maybe they've already served a lot longer and been held for a lot longer than they would have if they've been found guilty for the original charge, then they get released with no connection to treatment in the community. What we propose is instead refer them to an AOT program, and then they have outpatient treatment under a civil commitment that will stay with the person. They'll be connected to treatment and reduce recidivism, and actually help lift a person out of the problems in the system. So we recommend that wherever it can be done, where there is an existing AOT program. And if you're wanting to find information about how many state beds you have in your state, we recommend taking a peek at this report that came out in January 2024. It was called Prevention Over Punishment. It's right on our website. Shanti Silver and Elizabeth Hank collected data for civil and forensic state psychiatric beds from all over the country and provided a comprehensive analysis of the situation. There's also a report on our website that shares with you how they came up to the number of between 30 to 60 beds per 100,000 people. That can be useful to know about as well. And we also produced a supplement where for each individual state, there's a certain amount of information like names and locations of the state facilities, occupancy rates, the average length of stay, waiting lists, rankings relative to other states. It's a helpful place to go look on one page for basic information that you can share with legislators if you're advocating for more beds. And you can also access information on this page where it shows a map of state SMI resources. You can go and hover over a certain state and click on there, and there will be a little hyperlink that comes up. And you can click to your own state and find quite a bit of information, including resources about services that are available in your area, but also where you rate in terms of the number of state beds that you have, and other information that can be helpful. And at the end of the report, our recommendations were that there is a need to balance the need for forensic and civil beds at our state hospitals. We definitely need to have states addressing staff recruitment, retention, and training because we know we have a workforce shortage, and we do have a shortage of people who are adequately trained to help people with severe mental illnesses. We need to increase reimbursement rates for mental health services. Many people don't know this, but somebody being seen for psychiatric care, those doctors are getting reimbursed at much lower rates than somebody is if they're seeing a family practice doctor or an orthopedic surgeon. And that's a problem. That's part of why we have shortages of mental health providers. And we do recommend that states do data tracking for their state hospital bed numbers, wait times for discharge once they are better, and competency restoration. Again, if you're not measuring it, it's difficult to analyze where you need to put your funding and resources to improve things. There was also a supplemental report that was called a qualitative report. TAC put out a request to people that are on our lists for being associated with the Treatment Advocacy Center for people who had been in a state hospital or family members who had been in state hospitals to share their experiences in the state hospitals. And this request for reporting in came before I joined the Treatment Advocacy Center to work for them. And I saw that request, and I knew from being connected to so many people across the country that most of the stories would be pretty bad, right? We have a problem with quality care in our state hospitals still. And I actually decided I wanted to write in because our son did have a wonderful experience at the state hospital in Independence, Iowa. And I wanted to share that that was possible because for 60 years, we've thought that the answer to having bad quality of care at state hospitals was to continue to shut them down and that it wasn't possible to make it good quality care. So I wanted to demonstrate and share that actually our son received the best care he ever had and still has had at our state hospital. He had multiple professions working with him, from psychiatry to psychology to nurses to peer support specialists. He had all of his medical needs, dental needs, vision needs caught up with. They had excellent nutrition, exercise, a regular routine. It was the most comprehensive treatment he ever received. And to this day, 17 years in, it's been the level of care that he's most needed. And I wanted to make sure that people understood that this was absolutely possible to do, right? And we wanted to make the point that quality of care matters. We don't just want pills and beds. We want person-centered, comprehensive, effective, compassionate treatment. We need to have forensic patients treated just as well as the civil patients because they're basically the same people, people who just were allowed to get so sick that something bad happened. And we need to be able to do something about the problem of staffing shortages and high turnover. We need to help them with training of staff. In the outpatient world, we also need to build out that part of the continuum of care, right? We know that first episode psychosis programs with coordinated specialty cares are highly effective, but we don't have enough of them. Too many people having their first psychosis don't have access to these, so we need to be advocating for more of these programs. We need psychiatrists, of course, for medication management, but we also need to utilize therapists with evidence-based treatments like cognitive behavioral therapy for psychosis. We need more assertive community treatment teams, definitely more AOT teams and programs. Peer support can be hugely helpful. And insurance companies do need to be held accountable for actual parity. On the crisis end of the system, we know we need more mobile crisis teams integrated with 988. We need more crisis stabilization and diversion centers that will accept anybody, no matter what their insurance or lack of insurance might be. We need prompt emergency evaluations in the community and any facility built for crisis care. We need enough acute beds with adequate staffing and full scope of practice. We definitely need adequate state hospital or long-term inpatient beds for people who need a little bit longer to get stabilized and figure out the right cocktail of medications. And we definitely need accountability for responsible discharge and outcomes. We cannot accept hospital streeting patients with no plan for continued care after they are discharged. We also need the full continuum of care for the lifespan of the person, right? We need insurance reimbursement at the level of individual need. We need transitional step-down care upon discharge from hospital for some of the people. We definitely need more subacute care and partial or day hospital programs for people to help ease them back into the community after being in a more restrictive environment. Definitely need crisis residential and respite programs that can be really helpful. Affordable supportive housing covered as medically necessary, right? That would be extremely helpful. The development of an expansion of CCBHCs or certified community behavioral health clinics are really helpful because they are required to provide care to anybody that comes through their door, no matter their age, no matter their insurance. And they're required to provide medical treatment, psychiatric treatment, and substance use treatment all in one location or contract for it. And of course, we all know that Clubhouse International community centers are really helpful for people who need to find purpose, find community, be able to reach a higher level of recovery. But there are true barriers in the continuum, and we need to recognize that, especially when we think about anosognosia, and the need for an ability to help somebody who has no idea that they're sick. We need to have people understand that that's part of the brain illness itself, and that we need to be able to responsibly and compassionately step up with person-centered treatment for those people as well. Unfortunately, misunderstandings and underfunding have limited the rollout of AOT, but we're hoping that that will continue to change and improve. Providers do experience burnout, so we need to be doing more to provide help for those people. And we need to recognize that still insurance parity has not been realized. If you're interested in getting involved in advocacy, I highly recommend going to our Treatment Advocacy Center website. You can go to our Action Center and scroll down to the lower right-hand side of that page, and you can sign up for action alerts. We send out notices to people in states where we see bills moving that are helpful for improving the treatment programs and systems in your state. They're really quick and easy to use to add in a personal reason why you want to see a certain bill passed, and it will be sent off to the appropriate people on the right committee for that bill. I also recommend signing up for our SMI Advocate newsletter. We publish that twice a year. Our last publication was just in July. We list a huge list of bills that have passed that we've been tracking over the prior 6 months. That's a great place to go to take a look for ideas. Oh, they did this in Texas. Why couldn't we do that here? Let me print this out and take it to my legislator and give them the idea for a bill that would help us here in our state too, right? That can be really helpful. And in the meantime, the thing that I always touch on when I'm talking with providers, doing advocacy talks, is while there are those of us that are really engaged at doing systems level work to improve treatment systems from a legislative standpoint, we really recommend that each provider think about taking what I call the starfish approach, helping to work within the broken siloed system to find a creative solution one person at a time. I've seen that work locally when we know the right people to get a hold of to say, hey, we need to get this person into treatment. Can you help me get this person in the door? Can you help me keep them long enough so we can find the right supports that the person needs when they come back out of the hospital? One at a time, we really can take care of people better. And that is so much better than saying, oh no, the whole system is broken. There's nothing I can do. Personally, I'm done hearing those words. And so I really look for the people who are figuring out a way to say, oh, I don't know if I can do that, but let's try. That's the kind of attitude we need to try to instill. And with that, I'm going to go ahead and stop talking at you and offer up my email here for anybody who might want to reach out and open it up to questions.